Good morning. Let's all begin the next session titled Glaucoma 360 Degrees. The first presenter is Dr. Digvijay Singh. You can take the podium. He shall be speaking on glaucoma progression and target IOP.
Good morning, and thank you to AIOC and the committee for having me on this topic. And I think this kind of covers a very large part of glaucoma. So I'm going to just give us a sense of what we understand with target IOP and how we kind of look about changing it for glaucoma progression. What pointer is it? So target IOP is that IOP that we assume will not cause
Set
any.
the timer to 9 minutes. Yeah, Digvijay, you can
target
start.
IOP is that IOP which we assume will not cause any further progression of glaucoma, and that's the pressure we assume is the right pressure for the patient, and what is the pressure that we want to maintain that patient on. And this diagram from the EGS publication kind of tells us what target IOP depends upon. It depends basically upon clinical and demographic parameters. Target IOP has to be low in cases where you're having an advanced glaucoma, you've got a long life expectancy, you've got additional risk factors, you've got a fast progressing patient, or you've got a situation where the baseline IOP was not very high to begin with in the first place. So probably IOP alone was not the risk factor there. In those places you want to keep a low target IOP in the lower teens, as against higher target IOP which you can in the opposite situations of these. So there are various ways to look at target IOP that over time we have been told. But essentially, if you look at this diagram on the side, if there is somebody who's got a mild glaucoma, you can look at 15 to 17 millimeters of mercury, up to 18 millimeters of mercury. Somebody who's got like a moderate, you can look at 12 to 15. Somebody who's got a severe form of glaucoma, you want to keep it as low as possible, maybe to 10 or 12 millimeters of mercury, or even lower. And this is a diagram from a publication by Dr. Ramanjit Sehota, and this tells us that there is, that you start with one topical medication in the beginning, look for 2 weeks, look for the change in pressure, and then go on to another medication to be added to that if needed. But in cases of severe glaucoma, it says that you first need to urgently correct the IOP, and therefore you could use acetazolamide. But this could just be like a reference of what to do once you've decided your target IOP and how to go about it. But supposing you think you've achieved your target IOP and there is still a progression that's happening, then what? So first you confirm, is there really a progression? Was it an inattentive field? Was it a refractive error? Did a cataract crop up? Was there some other reason for the field to show a progression? And if there was a progression, then was your target IOP really achieved? Do you think there was some fluctuations that were happening in between? Do a diurnal control. Maybe there was some angle closure attacks that were happening. So these are the things to ask yourself that question. And if there is, then you first need to think of lowering your IOP further. And one of the things that you could do is to lower the target IOP using medical therapy or other therapies that I'll just discuss briefly, but also look at it from an angle closure point of view. This is something that gets missed very often. So you probably need to look at doing a YAG iridotomy. And if both of these things seem to be okay, then look for non-IOP causes. These causes could be obstructive sleep apnea. You can treat that with CPAP. It could be nocturnal hypotension, particularly seen with normal tension glaucomas. You need to correct that by stopping beta blockers, giving some inotropes. It could be cardiovascular causes. It could be carotid stenosis, and you need to treat that with stenting. So treat the non-IOP causes in situations where you think you've done well, you've got the right target IOP, and you're still having progression, and you're sure that there is a progression despite your IOP being controlled well throughout the day. Remember, there are fluctuations, and that does cause some element of problem. But if you decide that no, the non-IOP causes are also being looked at, then the only option that you have is to further lower your target IOP, which you could do with medical therapy, surgical laser therapy, or surgical therapy. And these are 4 scenarios. So for example, in the first scenario here, you can see that you had a mild glaucoma. Target IOP initially was, let's say, about 17, 18. Then you can reduce it down to 15. You can add another medication there, and that works very well. Medical therapy works well in these cases, or even a laser trabeculoplasty. If you had a target IOP which is already about 15, you can step it down to about 12 or so, and again you can add another drug. You can think of a minimally invasive glaucoma procedure here. But if your target IOP already was about 10 or 12, then you want to reduce it further down, and in those cases often a surgery is what you would need. And in cases of normal tension glaucomas, in the 4th scenario, we would be looking at, definitely look for non-IOP causes, because if the pressure already is 8, 10 or 10, 11, not going beyond that, then there is something else that is causing the glaucoma to progress. So when does surgery come into place in these cases? Surgery comes when you're looking at single-digit IOPs. You cannot achieve single-digit IOPs with medical therapy. You cannot, and if you want to remove fluctuations, surgery is the best form of removing fluctuations over time. Also in cases where there is a cost factor, it's slightly more frugal. But yes, one has to remember that there are risks involved in surgery, and it's not as simple as a cataract surgery or any other surgery. In fact, recently I was asked by some, a media house that, is glaucoma surgery a major surgery? And, the idea is it is a major surgery, but it is not a surgery to be feared. So it is a surgery that you can do. If done well, properly, it serves its purpose very, very well. So these are the indications for having a glaucoma surgery. And what sort of surgery you would choose would depend. From a minimally invasive surgery, if you're looking at reducing the, if you're looking at a target IOP which is somewhere in the mid-teens, or by reducing it by about 10 or 15%, these surgeries work well. And these are the, you could use stents, you could do GAD, goniotomies. If you're looking at further lowering of IOPs, and you have that, you have the right scenario, then trabeculectomy still continues to be the gold standard. Though I'm, beginning to realize that now a lot of places trabeculectomy is no longer their first choice. They're managing very well with the minimally invasive surgeries. And then of course you have the glaucoma drainage devices, or the implants, or the valves that are used. So again, these all would come into place in situations where there is a progression that's happening. Target IOP seems to be achieved. There are no other risk factors, and you really want to lower it down to the early teens or even below to single digits. That's where you step in with surgery. Thank you.
Thank you, Digvijay, for that wonderful enumeration of about target pressure. In practice, it generally boils down to primarily you need to reduce the pressure by 30%. If there is a progression, aim for a further 20% drop. That is for the general ophthalmologist. But you need to take into consideration all the facts and that Digvijay enumerated. Now it is my proud privilege to invite our guest faculty, Dr. Deepak Edward from USA, to speak on neuroprotection in glaucoma. Welcome, sir.
Good morning, and thank you for the invitation to speak at this symposium. My topic today is talking about neuroprotection and where we are in 2024. So our learning objectives today are to understand the fundamental principles of neuroprotection. Why is it important? A brief thing about history, and what, if any, options are available today in our way we treat patients with glaucoma. So just going back to some of the basics about the retinal ganglion cell, which is the cell that dies in glaucoma at the back of the eye, is that these cells die by a process known as apoptosis, or programmed cell death. The cells die without inflammation, without necrosis, and they become pycnotic like this. And if you do special labeling with an antibody called tunnel, and you can detect these cells dying. And how do these cells die? By apoptosis. Of course, the mechanism is somewhat complex. Most of the damage occurs at the lamina cribrosa, affecting the ganglion cell, and where is the damage in glaucoma. And as you will see in the next slide, the mechanisms of apoptosis is complex. You have extracellular matrix changes at the lamina cribrosa, making it more stiff. You have reduced axoplasmic flow, which causes growth factor deprivation in the retinal ganglion cells. We'll talk a little bit both about therapies, giving more growth factors. There are CSF changes that can happen that can affect the optic nerve, and also cytokine and matrix metalloproteinase damages produced by the astrocytes in the optic nerve. So it is quite complex. So if you look at this in a different way, you have an initial insult of increased IOP, again, not in all cases, but in most cases that we're talking about. You have mechanical compression, axoplasmic flow deregulation, all these processes happening, the end result being a dysfunctional and retinal ganglion cell, and somewhat irreversible visual loss. Ganglion cells can recover, especially after you lower intraocular pressure, those that are sick. But if once they die, you have irreversible visual field loss. So why do we talk about neuroprotection? The only way we can right now treat glaucoma, real modifiable factor, is lowering the intraocular pressure by medications, lasers, and surgery, as our former speaker talked about very nicely. But there are limitations of treatment, side effects of treatment, medicines, inadequate IOP control, poor compliance, and the need for ongoing monitoring. And sometimes in patients who have advanced glaucoma, the damage persists despite lowering the IOP. So neuroprotection is really looking at non-IOP related interventions that can prevent or delay glaucoma loss independent of IOP. So I'd like to briefly touch upon this older study using this molecule known as memantine, which was targeting a receptor called the NMDA receptor on a postsynaptic neuron, that is the ganglion cell. And this was the theory of excitotoxicity. So Allergan funded a very large clinical trial, which is probably the most expensive trial in glaucoma history, but the trial failed. And this put back research into neuroprotection in glaucoma by many, many years because people were very discouraged after the results of this trial. So what's new? Are there any agents on the market? We'll talk a little bit about how you can enhance neurotrophic factors, mitochondrial dysfunction, how that is being addressed, and a few words about the others on the list. So one of the things, this is not something new, but it's kind of old, but a nice paper to realize, looking at brimonidine as a neuroprotectant, and there was this very nicely designed 4-year double-masked randomized multicenter clinical trial using brimonidine and timolol, and the graph kind of summarizes the results, showing the protective effect on the visual field with brimonidine compared to timolol. So there's been some controversy, as they say, well, maybe brimonidine is useful, but it also, timolol might be potentially harmful. But animal models kind of support that brimonidine can enhance survival of RGCs independent of IOP. What about neurotrophic factor administration? I previously alluded to the fact that growth factors are no longer present, and that's why these ganglion cells die. So there are two very exciting studies in the last few years looking at, these are phase 1 studies, looking at a short course of topical recombinant human nerve growth factor. There were 16 randomized subjects, and again, being a phase 1 study, they really looked at safety. But the interesting thing in this very small subject group, there was trends in improvement of the Humphrey visual field and RNFL, and a phase 2 trial is being planned and executed. A more exciting study, which was very recently published, again, this is using a little device that contains pigment epithelial cells that produce ciliary neurotrophic growth factor. You implant it into the pars plana, and these cells continue to secrete CTNF. And the primary outcome, of course, being a phase 1, was 18 months of safety. But the implanted eyes did show some increase in RNFL as measured by OCT, and there was some improvement in visual fields, though not statistically significant because of the small numbers, but the untreated eyes actually got worse. So we're waiting for the phase 2 results on this one. What about mitochondrial dysfunction? Again, this is a very busy slide, but here is a slide this is a study that came out of Australia, showing how vitamin B3, when given at very high doses, improved visual function and perimetry in patients. There's 2 large trials going on in the US and in Sweden that started in 2022, and we really won't get results till 2026 to see how this very simple treatment that helps mitochondrial dysfunction help us in neuroprotection through alleviating mitochondrial dysfunction. What about stem cell therapy? So I'm not going to spend much time because there is, you can use mesenchymal stromal cells or human embryonic cells. These have not found to be very effective. The approaches have been, to restore TM function or directly replace retinal ganglion cells. Many studies have been registered at the, clinical trials database, but we haven't seen results from this. One also should be aware that there's a series of cases published out of Bascom Palmer showing someone injecting autologous stem cells for AMD, and these eyes underwent terrible visual field loss. What about gene therapy? Again, not very successful. The attempt of gene therapy is really to get more growth factors in using things like brain-derived growth factor, the TRKB receptor, and all neurotrophic factors so that the cells could overexpress them and protect them but there are no human studies, and even the studies in animals have not been very promising. What about antioxidants? So there are plenty of antioxidants on the market, and the bottom line is clinical evidence of effectiveness is inconclusive. Citicoline is one that has been widely touted, and again, there's very little data to support its benefit. This is available on Amazon in the United States, and it's a very popular drug bought by patients. What about immune modulation? So in the animal model, it seems to be really good that if you can, because there's a role of immunoregulation in death of RGCs, but there are no human trials to date. So what about a summary of what we just said? Despite ongoing effects, the neuroprotection is a challenge because of the complexity of glaucoma. You saw the different mechanisms that are involved. There's individual variations, and the measurement of neuroprotection is also hard, and regulatory hurdles are also difficult. Long-term efficacy is not known, and patient access is kind of limited and costly, but I think there is hope. So thank you very much for this invitation, and thanks for having me here.
Deepak Edward. That was nice, but as we all know, neuroprotection still seems to be a myth. And yes, there is hope at the end of every dark tunnel, so we shall wait and see what happens. With this, can I get the next speaker, Dr. Sandeep Mittal. He's going to talk to us on something very different. Is Dr. Sandeep Mittal here? No? We can go on to the next speaker. Yes, Dr. Manoj Mathur. Yes. He's going to talk to us about structure and function correlation in glaucoma. Very important topic, and I'm sure he's going to do good justice to
Good morning. A very basic talk, especially for the general ophthalmologist. So, what are the practical pearls when you think about structural and functional correlation? You need to have a proper disc evaluation, need to correlate that structural defect, suspected defect with the OCT, and then correlate it functionally with the Humphrey visual fields. So structural and functional correlation forms the cornerstone in the diagnosis of glaucoma. When you see disc evaluation, you need to evaluate the disc in these following 7 parameters. One is most important is you need to make a forceful decision as to what is the size of the disc you are seeing. If you see this disc on the screen on the left with the spot size of 1.5 millimeters, you see a small disc, and on the other side you see a large disc compared to that 1.5 millimeter diameter. The optic disc cup, we all know this is the standard. The cup disc ratio vertical is more important, and you need to look out for cup disc asymmetry. When you see these 3 discs here, one on the left is the small disc, one on the center is the normal disc, and one on the right is the large disc. What is it that you are seeing? That the cupping is different in all the 3 normal discs. So the lesson, cup disc ratio varies with the size of the disc, and cup disc ratio on its own is not significant. Then a large cup can be normal for a large disc, and a small cup abnormal for a small disc. So importance varies with the disc size. Hence, the moment you look at the disc with a 90-degree lens in your chambers, always make a forceful decision as to what is the size of the disc you are looking at. What is important? That optic is only a surrogate for the neuroretinal rim. And when you say neuroretinal rim, you need to see whether it is pink, pale, or notching is there. And the important thing is you need to see for the so-called isn't rule that the inferior rim should be thicker than the superior, which should be thicker than the nasal, and then that should be thicker than the temporal. So you need to look out for any vascular changes. These are theoretical, like nasal shift of the vessels, bearing of the vessel, and the bionetting of the vessel. And always rule out the presence of a hemorrhage. Look out for a hemorrhage and make sure that there is no hemorrhage. The nerve fiber layer defect, it is a dark wedge, touches the disc and then fans out into the periphery. You see a small hemorrhage there, and as a result of that, you see this nerve fiber layer defect, which can be seen better with a red-free light. The peripapillary atrophy and the chorioretinal degeneration also should be seen and taken into consideration when you are evaluating the disc structurally. Then you need to correlate this with an OCT. Here I am taking the help of a OptiView OCT, the main aim of the image processing is to measure the RNFL thickness, optic disc rim, and cup. And then the ganglion cell complex is a vital component of this machine. And also with this we can measure the CCT and look out for the angle scan. This is a normal OCT. When we see all these parameters, because of the positive time, I can't explain every component. Then you need to correlate this structural defect with a functional change in the Humphrey field analyzer. And when you analyze an perimeter printout, you need to see and interpret in the following 8 points. And in one slide, if you ask me to tell you about visual field, if you see on the left, if there is a diffuse suppression in total deviation with all points being normal in pattern deviation, that may be a cataract. If you see the total deviation and pattern deviation similar, there can be glaucoma. And if you see the total deviation totally suppressed, and when you remove the diffuse component of suppression from the total deviation, what stands out in the pattern deviation is the glaucoma. So probably cataract and glaucoma. With this, let's move on to structurally and functionally correlate. Here you see a large disc with a 0.75 cup with a normal visual field. Here if you see the inferior temporal notch that forms an early defect in the superior nasal step. Here you see there's excavation of the superior rim, which translates into an inferior arcuate defect. Here if you see, concentrate not on the color cupping, concentrate on the dipping of the vessels. Its near total cup results in a field like this. And if you detect this kind of a situation, always correlate with a 10-2 for follow-up. And now if you see, always look out for pallor of the temporal pallor, especially you won't be surprised if you get a hemianopic component, and this is the other point. Now, correlation with the, correlation with the OCT. If you see this disc, there is an inferior temporal notch. You see a clear-cut nerve fiber layer defect, and then if you see the OCT, there is an inferior temporal defect here, significant defect. If you see the GCC correlating perfectly, and if you see there is a superior arcuate suppression with a focal defect in the nasal step. This is exactly what a structural and functional correlation needs to be looked at. And if you see this disc, there is definitely an inferior excavation here. You see the dipping of the vessel here. If you correlate with the OCT, you also see a superior temporal defect as well as an inferior defect on the OCT, and that perfectly correlates with a superior arcuate defect and the focal defect in the inferior nasal step. And if you see this here, you always look out for hemorrhage. Now this hemorrhage was there and the visual field was normal, and you need to concentrate and treat this patient, bring down the pressures to the optimum level, because if you see the field on the right side, if despite maintaining thing, you are now slowly detecting a focal glaucomatous defect in the inferior nasal step. Now, I would like to conclude by showing you this. This was the OCT where this was my learning curve in OCT, my first learning thing. I took this, I subjected this patient to OCT only for the intraocular pressure variation between the two eyes. And now what do we see? Normal visual fields. But if you see the OCT, the left eye or the right eye shows a superior temporal and inferior temporal defect. Then you go back, look at carefully, then I started saying, oh, is there some nerve fiber layer defect here? Here, something like that. I put the patient on treatment. Then I read about the GCC. This was my initial experience with the OCT. So I called back the patient. I did the GCC. Then everything is normal. The right eye, the nerve fiber there is normal. Go back and see. In April, I had a superior temporal and inferior temporal defect, which is now vanished. What is the reason? If you see the centering, the man behind the machine, if you see here, it is eccentric. That is the reason why a peripheral area was checked, and that gave the thing. Now this is a perfectly centered OCT with a normal retinal nerve fiber layer. What is the lesson that we get to know about this. Imaging technologies do not confirm diagnosis by themselves. Imaging technologies at best only complement the clinical judgment of the glaucomatologist, and structural and functional correlation by stereophotographs and visual fields is a vital tool. A good collaboration with the relevant imaging technology does act as a bonus. So the cornerstone of glaucoma diagnosis, structural and functional correlation, the way suspected a defect in the optic disc as a first step, further evaluate the patient, if necessary correlate with the OCT. Once you establish a structural defect, this defect needs to be correlated functionally with the Humphrey visual field, and then only you will be diagnosing that case as a glaucoma. Thank you very much for your patient hearing.
Thank you, Manoj sir. Indeed, it was a beautiful correlation of the structure and function. So with that, we invite our next speaker. That's Dr. Suman Biswas to deliver a lecture on SLT as primary therapy in glaucoma. And with that, we can take one questions if there are any. Because as very beautifully derived by sir, that always we don't have to rely on a single investigational finding. The glaucoma diagnosis, the treatment, everything needs to be in a holistic approach.
Hi, good morning, everybody. Greetings from Burton-upon-Trent in the United Kingdom, the Queen's Hospital, where I work. It gives me tremendous pleasure to deliver this talk on primary SLT treatment, not just because I'm passionate about SLT. I've done a few thousand SLTs over the past 10 years or so, but because I'm delivering this talk in Kolkata, my ancestral hometown. I haven't lived here. I studied in Jipma, Pondicherry, before moving to the UK. I remember in 1992, I traveled as a young doctor to attend the AIOC conference in Kolkata. It was at the nearby Salt Lake Stadium. From then to now, it gives me tremendous pride and satisfaction to see how things have changed, not just in the venue and the quality of the programs, but how much Indian ophthalmology has advanced over the years. Coming to the remit of my talk, selective laser trabeculoplasty is now the default choice, and it is the preferred practice pattern, not only in the US and UK, but many other countries in the Western world. I have already noted that ophthalmologists in India are somewhat reluctant to adopt SLT because many feel that it doesn't work. One of the objectives of my talk will be to convince and persuade that yes, it does if done right. I don't have any disclosures to make. Let's look at the background a bit. The glaucoma laser trial was done way back in 1995. It compared the efficacy of argon laser trabeculoplasty, which was what was available at that time, and it was compared to topical medication. The laser treatment was as good as topical medication. That was the outcome of the study. Obviously, we didn't have selective laser trabeculoplasty at that time. Now, selective laser trabeculoplasty was first done in 95, but actually it was Mark Latina in 2002 who really made it popular. The SLT versus medical therapy as a primary treatment was studied in the early 2000s and published by Katz et al. In 2012, and it simply showed that SLT was as good as topical medication. So obviously, SLT was gradually replacing argon laser trabeculoplasty because, as we all know, argon laser does damage by photocoagulation of the meshwork and therefore lead to scarring, and you can't repeat it, whereas SLT is more selective for the pigmented trabecular meshwork, and it acts by laser photothermolysis, and it also doesn't do any collateral damage. It provokes inflammation, cellular proliferation, remodeling of the meshwork, increases the outflow, and thereby reduces the pressure. So the advantage is we can repeat it. So obviously, argon laser gave way to selective laser, and SLT was the dominant laser form. primary SLT for open-angle glaucoma and ocular hypertension was also studied and published by Garg et al. In ophthalmology in 2019. But it was really the LIGHT trial which came out in 2019 as well, and this was done by Gus Gazzard from Moorfields in London. And it was a multi-center trial. We were all part of the trial at one stage. And that landmark study really brought SLT to the fore, because then people started noticing it more, and this study was scientifically very robust. What it did was it compared SLT with topical medication by randomizing patients and then following the outcomes. The trial results showed that there was not only better intraocular pressure control, the glaucoma progression was slower, and that was 3.8% compared to 5.8% with topical medication. Not just that, in systems which have got universal healthcare, like in the UK, cost was a factor, because the amount of money that is spent on drops is much more and outweighs the cost of installing a laser machine and doing a one-off laser treatment. The cost savings in UK, I'm giving the figures from there as published, is £451 per patient per year, and I'm sure it'll work out significantly even in India. The follow-up showed that there was a 74.6% drop-free after treatment with SLT at 3 years. And not just that, in the trial, nearly 58.2% achieved that with only one SLT session, which was significant. Sorry, how do I go back? Can you go back, please? Yes, thank you. So what are the advantages of SLT over topical medication? Again, I'm looking at the published literature. Zhou's paper in ophthalmology therapeutics in 2017 showed that 35.9% reduction of IOP was achieved in open-angle glaucoma. In the LIGHT trial of 2019, it was a phenomenal 74.2%. And that was probably because it was mostly a white Caucasian cohort. And not just that, they selected treatment-naive patients. And we know that although SLT can be used as an adjunct to topical medication, it works best when you are having a treatment-naive group and instituting as a first-line treatment. SLT is very safe and well tolerated. It is a very short, intense pulse. It is 3 nanoseconds, and there is no pain, just a mild patient discomfort, a bit of redness, which settles within 1 or 2 days. Sometimes steroids are used, but many times people don't use steroids. And because it doesn't do collateral damage, it is very selective. The advantage is it can be repeated. Usually it lasts for about 3 to 5 years. It varies, but if it is not working and fading away, you can simply repeat it. I have already talked about the cost effectiveness, and it's not just the UK, but studies have been done in Canada as well, and Lee et al. In the Canadian Journal in 2006 did allude to the significant cost savings. In fact, when we were putting in a business case in our hospital, and that was in 2013, I had to demonstrate that, yes, it will be worth buying the machine, because the laser machine at that time costed about £30,000. It's about the same in UK even today, because, of course, the technology has become cheaper, but inflation has also countered it. So I don't know how much it is in India, but the cost of the machine was, to put it simply, much more recovered within just a year, and within 2 years, we had enough savings to be able to say that to the management that we are actually saving money 3 times over within 2 years. So that was the business case to buy the laser. Not only the cost, but it is also useful in areas where you have limited access to either glaucoma medication or surgery. In some remote areas, patients may not get hold of medicines regularly. And of course, the sophisticated surgeries may not reach many remote areas, but you can bring them just to one center, do the laser, and that might give you some time. There is also the advantage of reduction in reliance on daily topical medication. Patients sometimes get the freedom of not having to do the drops every day. And sometimes there are patients who are always poorly compliant with drops. In that sense also, you can do a one-off treatment, and that's an advantage. So the disadvantages are the IOP spike, which again is very rare and can be preempted by treating beforehand with iopidine or apraclonidine and brimonidine. There is iritis because it can cause inflammation, but that is again very limited. I have already said that it can be repeated, and there are some articles about variability in the outcomes. So there are articles like Beletsky's of 2019, where there has been variable outcomes based on protocol and operator experience, and also Song's paper in Glaucoma in 2005, which says that there was only 60% effectiveness if done over 180 degrees. So what I want to say in conclusion is that the spot size is 400 microns, and it has to be placed centered on the pigmented meshwork. And it should not be either going towards the corneal endothelium or towards the iris, because the spot size itself straddles between the Schwalbe's line and the iris root. And if the plane is correct, if the focusing of the meshwork and the pilot laser is accurate, then it will be confocally delivered. And if done like this, patiently, then it does work. To summarize, we know the benefits from the light study and various other studies. It is a very convenient procedure. It leads to cost savings, and it gives patient independence. So I would say that it is worth a try as a primary modality. Thank you very much for inviting me.
Thank you, Dr. Suman Biswas. That was a good exposition about SLT.
I just have a little comment to make. I've got a lot of experience with SLT myself, but like you said, I have not seen results of SLT last for over 3 years. Between 3 and 5 years is something that we've just never seen. In fact, over 18 months, between 18 months, we have to keep a repeat follow-up to make sure that they need medications or they need a repeat SLT. And the effect that you get post SLT, repeat SLT is much lesser than the result that you get the first time you do the SLT. Also, SLT, if done in a naive eye, gives you much better results than if you do it on a patient who's already on medication. So that's, I think that's a big take-home message for people, because if patients are already on medications, then taking them off medications and giving them SLT is not a very good proposition. And hence, I think, the Indian continent or maybe the Asian subcontinent is not in such a big favor of SLT.
Can I respond now?
Yeah, you can.
So what we are trying to say is that it is to be considered as a primary modality, not as an adjunct. And if you are choosing as a primary modality, it will only work in some cases of open-angle glaucoma, most cases, and ocular hypertension. So for instance, primary open-angle glaucoma is fine, pseudoexfoliation and pigmentary glaucoma is fine, not so much for uveitic open-angle glaucoma or steroid-induced glaucoma. So that's the case selection. But the main difference comes about if the technique is done properly. Because I didn't have time to elaborate, but I politely tell off my trainees who will finish doing SLT in 10 minutes flat. Because it's impossible to do 90 to 100 burns over 360 degrees without being very meticulous and with attention to detail. It is not like a yak capsulotomy. So if it is properly focused, and if you see the champagne bubble reaction in 50% of the doses delivered, the main thing to achieve that is by modulating the power as you go along the angle. My preferred practice is I start with the inferior angle with the reflector mirror on top, and then I keep the power down because we know that the pigmentation is more in the inferior angle, and then I step up the power to see the champagne bubble and then go sub-threshold where bubble again. And for the champagne bubble as well, if it's a huge stream, that is a bit too much power. Of course, if you get a white spot, that is not SLT, that is more like ALT. So the champagne bubble has to be just a little hint and then subthreshold, and like that, 50% of the bursts all around have to have the champagne bubble. That is the kind of meticulousness. If you have got patients like that, even then 10% in my hands don't work. So how I do it is I try with one eye at a time, and if it works in one eye, I go on to the second eye with full confidence. If it doesn't, then I rely on topical medication. But also I always, when you see the patient in the clinic for the first time, you don't have access to SLT on that day. So I start them on a prostaglandin and then schedule the SLT. And SLT takes some time to work, we know. So after about 2 months or 3 months, if the SLT has dropped the pressure enough, then I stop the prostaglandin. So that's my practice pattern. But there are many patients in my hands who are drop-free. Thank you.
Thank you, Dr.
Thanks.
Suman. Now we have another speaker again from UK. Welcome, Dr. Pankaj Agarwal. He will be speaking on role of cataract surgery in glaucoma.
Thank you very much, Dr. Mathur, and thank you very much for the AIOS for inviting. Excellent session so far. So my talk is on the role of cataract surgery in glaucoma. I have no financial interest with regard to this talk, but I will have some disclosure that I don't do refractive surgery. I do a lot of cataract surgery, and I'm still a trabeculectomy surgeon, although I have done all the mix, but I still believe in trabeculectomy strongly. So I will be highlighting some of the issues regarding the cataract surgery in glaucoma. First, the efficacy of it, then some effect on the diagnostic, some therapeutic consideration when you land up in patient with angle closure, pseudoexfoliation glaucoma, how can we look into cataract surgery mixed with other procedures, and some small tips on cataract surgery in glaucoma patient, mainly the advanced and uncontrolled glaucoma. So every one of you perhaps are aware of this landmark trial published in Lancet looking into the effect of early lens extraction compared to peripheral iridotomy in PACG and PAC. And this study, we were part of it as well, and I think it changed my practice, how I manage angle closure patient. The study shows not only is much more efficacious compared to peripheral iridotomy, but is improved the patient quality of life, is cost effective and safer. Look into the chronic angle closure and how it compares the lens extraction with trabeculectomy, and this study from Dennis Lam, we showed, yes, trabeculectomy did help to reduce the number of drops, but it came with 10 times more risk of complications. Now we go into the acute angle closure. Hot eyes, and really you don't want to do a trabeculectomy when the eye is so hot. Now this study from Dennis Lam group compared early phacoemulsification with peripheral iridotomy to look into the efficacy in the management of acute angle closure. And no surprises, this showed that the early lens extraction not only was much more efficacious in reducing the intraocular pressure, but the angles were much more open for a longer duration. And in fact, in patient with, most of these patients are elderly with cataract, and the early lens extraction was a definitive management in most of these patients. That's what I see in my clinical practice as well, that most of these patients don't need any further glaucoma surgery, and they're managed very well on their drops. There's some more evidence suggesting that if you do early lens extraction, just as soon as you can break the acute episode, it's much more effective in the longer term. Now let's look into the open angle glaucoma. We are very much aware of the angle closure. In open angle glaucoma, this is not new. For more than 50 years, there has been evidence to show that there is reduction of intraocular pressure after a routine cataract surgery in any glaucoma patient. And there are lots of publications. But this landmark trial, OATS trial, showed that there is a significant reduction in the intraocular pressure after a routine cataract surgery, and the effect was sustained for more than 3 years. The preoperative intraocular pressure was a strong predictor of postoperative reduction. So the higher the intraocular pressure, the greater the magnitude of IOP reduction following surgery, and to the extent of 6 to 7 millimeters. Now, we look into the cataract surgery and pseudoexfoliation. For some reason, where I am practicing in Edinburgh, and there are a lot of pseudoexfoliation, and that's what I see in my practice, that the effect on the intraocular pressure is much higher in not only the eye with the pseudoexfoliation, but in the contralateral eye. One of the more important findings is that the pseudoexfoliation eye with a history of prior laser or a trabeculectomy or any glaucoma filtering surgery may not have as great an effect as no prior laser or surgery, which again indicate that you may want to do the cataract surgery earlier and perhaps before you do any laser or surgery. Again, we are aware that these cataract surgeries are not easy in the pseudoexfoliation, comes with a higher risk, but the risk won't get any better by delaying the cataract surgery. So again, that is something to think about. The drop in the intraocular pressure is sustained for much longer than the open angle glaucoma. Now let's look at the mechanism of reduction of intraocular pressure. We know that the pressure gets better, but what's the mechanism? Mechanism is much more clearly defined in angle closure. It relieves the pupillary block, and there is a positive relationship between the IOP reduction and the preoperative lens vault measured by the ASOCT. The mechanism is much less known in open angle glaucoma, but there are several hypotheses to suggest some of the mechanism by which the reduction in the intraocular pressure happens in open angle glaucoma. Now, let's look into the diagnostics, and there is evidence from this study from India that the increase in the RNLF thickness after the cataract surgery, which is more pronounced in the inferior quadrant, which is more affected in the glaucoma. So what it does suggest that we may need to establish a new baseline after cataract surgery with regard to the OCT. There is more evidence to suggest that the effect is not only limited to a spectral domain, but also the time domain OCT. So for both the types of OCT, there is a significant impact of cataract on the OCT reading. Let's look into the visual field, and I think Dr. Mathur already alluded to the effect of cataract on the various parameters in the visual field. This study suggested that the effect is more on the mean deviation, and both on the mean deviation and pattern standard deviation, and perhaps the VFI is a better index of measuring glaucoma progression in patients with cataract and glaucoma. But there was another study which suggests that from UK, which suggested that the effect is more with the mean deviation, and you can pretty much safely use pattern standard deviation for the progression. But we need some further studies to find out what are the robust perimetric measure. But what we definitely need to know is we need to re-establish the baseline after cataract surgery with regard to the visual field for our glaucoma patient. Now, so there are clear advantages of thinking about cataract surgery. I'm not a huge fan of combined surgery because I feel the combined surgery, the chances of failure are much more higher despite using mitomycin. So you have to look into individual cases and see whether you can do the cataract surgery before the trabeculectomy. It may help to reduce the intraocular pressure with a sufficient that you may wish to postpone the trabeculectomy, or you may need to re-establish the baseline with regard to the diagnostic tests. The pseudophakic eyes, we all know, have a less risk of lens cornea touch if there is a hypotony. Just going back to the previous slide. And some people may avoid iridectomy if patients are on aspirin or any anticoagulant to decrease risk of hyphema. We all know that the cataract surgery after trabeculectomy can lead to trabeculectomy failure, and that is also avoided if you do the cataract surgery before trabeculectomy in some of these patients. We all know, and I can see a lot of buzz about the mix. Now, I have been using mix for last 4 years, and I think this may be something short-lasted. We started with eye stents and all this thing. Now we are moved to hydrous, pressure flow, Omni, and again, I think the effect may be a short-lasting. But again, that's another advantage of the mix, and most of these are combined with the cataract surgery, and we don't know whether the effect is mainly because of the cataract surgery or the additional mixed device, something to look into in future. So just some tips about cataract surgery and advanced glaucoma. Carefully consider if the glaucoma is really advanced, then the priority is trabeculectomy, and do the trabeculectomy first. I prefer to use only aspheric monofocal in advanced glaucoma patient and avoid multifocals and premium lenses. Again, it's all about managing patient expectation, remove viscoelastic, beware of a steroid response, and a close follow-up. So again, what is the ideal glaucoma surgery? We are still in search of the ideal glaucoma surgery, but these are some of the characteristics, and perhaps the cataract surgery lives up to the most of them, but it doesn't reduce the pressure to 10 millimeter. Is cataract surgery is one of the commonest glaucoma procedure. So again, the take-home message from this talk, Monday when you all go to your clinic, consider the role of cataract in your glaucoma patient. You may want to think about the visual field and OCT and think is there real progression or is there is a cataract. Consider cataract surgery in angle closure and pseudoexfoliation as a first-line treatment if the pressure is still high. Open angle glaucoma, look into individual cases and see whether you can offer some of the mixed devices in some of these patients. But it's all about managing risk and expectation. Thank you.
Dr. Agarwal, that was a very comprehensive outlook on cataract extraction and glaucoma, but I thought, you spoke about the EAGLE trial where it was a clear lens extraction, and we don't consider clear lens to be cataract at all, and there's a lot of controversy on whether you should do a clear lens extraction at all. But otherwise, I think, yes, we look at the, other parameters. You look at the lens vault, basically, and in open angle glaucomas, I think very clearly the OATH studies has shown us that you get a pressure reduction which lasts for only around 3 years, and you can't be sort of, misguided into thinking that doing a cataract extraction is going to look after our glaucoma. So you can do a cataract because a cataract is required to come out, not because you want the pressure to come down because of the cataract extraction. I appreciate that you want to look at your visual fields and your OCT parameters in a much better light, but then, it has its own role to play because cataract extraction is not a very simple surgery. It comes with its own baggage of complications. However, you were very, very explicit and very clear on how cataract extraction can be dealt with in patients with glaucoma. Thank you very much.
Thank you very much.
And
Thank you.
can I now get the next speaker, Dr. Mohammed Mahdi from Egypt. He's going to talk to us on advanced glaucoma monitoring and follow-up, a very, very difficult topic for all glaucoma consultants because monitoring and advanced glaucoma is something that all of us are forever looking at.
Thank you very much for inviting me here to present about this topic. What I'm going to talk about today is advanced glaucoma monitoring and follow-up. Why this group of patients are so important? Simply because it affects a broad array of daily activities with various socioeconomic and health challenges such as stigmatization, underemployment or non-employment, increased morbidity and mortality, and even increasing risk of driving accident, falls, as well as mental and health difficulties, including even depression. If we look at this graph, we could see in the United States, for example, that the cost of glaucoma management in advanced cases is 2.5 thousand up to, as compared to half to 1,500 a year. And most of this cost goes for the surgeries in the advanced cases and in addition to the low vision aids. From the epidemiologic aspect, a significant proportion of glaucoma patients are presented too late in advanced stage of the disease. For example, in UK, 38% of cases are presented while in advanced stage of glaucoma. In South Africa, for example, 45% of patients with glaucoma are presented while they are blind at least in one eye. What about the underdeveloped and the developing country? What should we know about this advanced glaucoma? We should know the definition, how to diagnose, how to follow up, what's the target intraocular pressure in these cases, how to treat, what kind of surgery are we going to offer, but this is away from the scope of this presentation. For the definition, we shouldn't stick that much to the golden standard, the perimetric definition of that version, the Anderson criteria, but we can redefine the advanced glaucoma as those with near total cupping of the optic disc with or without severe visual field loss affecting the central 10 degrees of fixation. Here is that version, the Anderson criteria, all of us are familiar with. What are the challenges in advanced glaucoma? We have challenges at different levels, one at the level of diagnosis and the other one at the level of the follow-up and the other one at the treatment option. How can we detect the progression? Detection of progression in glaucoma is not simple like the early and moderate stage of the disease that we can follow up with the different machines, including the imaging modalities and the visual fields, because in advanced stage of disease, the picture is different, and the disease progression didn't follow a simple linear progression, rather than it goes through an exponential model. So what we are going to concentrate with is to see the patient's symptoms and review its patient symptoms, identify secondary causes if it presents, monitoring the optic nerve structure and the functions, imaging devices, and how are we going to use it, and visual field changes. How frequent should we see this patient? Simply, patients with advanced glaucoma require more visits than other cases of glaucoma. Usually, we have to see them every 3 or 4 months, or even earlier, as deemed necessary if they have other risks. If we have to listen carefully to the patient and to pay attention to every word from his mouth, because simply subjective assessment of advanced glaucoma patient visual function is often the most important indicator of disease progression. Usually the patient is telling that their vision is getting dim and need more light, and they are unable to read. They are getting more difficulties in their daily activities. They couldn't see part of the words, they couldn't see the next line, they are booming into things more often than earlier, and sometimes there's a drop in the measured visual acuity. Also, they might experience transient visual loss. If we are going to assess the optic nerve, we should look at it in a different way a little bit, because simply we have lost most of the neuroretinal rim, and only very thin part of the rim might be present. Most of the advanced glaucoma cases are 0.9 cup disc ratio, so nothing to be seen simply with the eye, but we might use the spectral domain OCT, but not in all cases, but in parts, while we have still remaining retinal fiber layer thickness away from the roofing effect. If we are going to examine the optic nerve, we should carefully look at the disc hemorrhages that develop, especially at the margin, as it is an indicator for disease progression, and we should know that it is transient and it vanishes simply. Also, if we are examining the optic disc, we should look for the retinal zoom beta peripapillary atrophy, because with disease progression, it increases. As you could see here, if you look at the cup disc ratio in these cases, it is nearly the same. But if you look at the peripapillary atrophy, it is enlarging, as you can see here. If you are using spectral domain OCT, some people could claim that it is more specific, but it's not like this. If we look at the structure integrity of the optic disc and retinal fiber layer, in these cases, both of these cases, it looks the same, but if you go to the function, it's totally different, because the left one has less damage than the other one. If we have a hemifield defect, simply we cannot use, if you could see here this inferior visual field defect, there's completely loss of the retinal fiber layer here with the roofing effect, and nothing to be followed up later on with the spectral domain OCT. But the other half of the visual field is nearly normal with normal retinal fiber layer. So we can use the spectral domain OCT in such cases in following up the non-roofing part of the retinal fiber layer. Also, if we are going to use the ganglion cell count, it is not successful enough, because early in glaucoma, most of the ganglion cells are lost, but in advanced stage of the disease, we have a roofing effect, and no much ganglion cells are lost to be followed up here. But the visual field is the most important part, in addition to the clinical examination of the optic nerve and the visual, the patient symptomatology. visual field might be the only possible way to follow up with in advanced stage of the disease. Central 24-2 is might not be longer very sensitive to detect subtle changes in the optic nerve head because of the less number of points in this big area of the visual field and the wider space between the points. That's why if we have to follow up such a patient, we should spend that much time with the central 24-2 and losing time for getting no information because most of the peripheral field is lost. And most of the remaining part of the visual field is the central 10 degrees. We have to resort to examine the central 10 degrees of the visual field, and we can use size 5 instead of size 3 if no information is we get with the size 3. And sometimes we resort to examine the cardinal points around fixation or use the quadrant total sensitivities. For example, if we have to see here in this graph, the central 24-2, okay, just a moment, 24-2, we only examine 12 points in central 10 degrees instead of the 68 points with 2 degrees apart distance in the central 10. If you examine this patient with the center 24-2, you hardly see any defects here, but if you examine the central 10 degrees down, you could find the defect in the points which lies in between the examined points in central 24-2. Also, sometimes if we couldn't see any visual field island to be followed up in central 10 degrees with stimulus size 3, you could use the size 5 here to get more information to follow up. Also, the quadrant total sensitivities, we could use it for further follow-up or use point-wise comparison or the cardinal points for subsequent follow-up for such a patient. The challenge is for advanced glaucoma, we all know that we need low target intraocular pressure and a lot of things to be followed up here. That's why it's very important to manage these cases and with aggressive lowering of the intraocular pressure. And whenever a patient appears with lower office visit measurement of intraocular pressure, progression of the disease, with progressive disease, the fluctuation should be considered in such a cases. Thank you very much for your kind attention.
Thank you, Dr. Mahdi, for that wonderful talk about management in advanced glaucoma. As we all know, glaucoma is a very complex disease, so we need to know some guidelines as to how to go about it, managing that. And to enumerate the landmark studies, we have Dr. Shweta Tripathi.
A very good morning, I can say. A very good morning to all. And at the outset, I would like to thank AIOS for giving me this opportunity. So why the landmark studies are important when it comes to the glaucoma diagnosis? That's because it's all about the decision making, like ocular hypertensives, when to treat, not to treat, or treat them, then as to what are the things which we have to keep in mind. How much IOP? These are the questions which arise when we approach a glaucoma patient. So how much IOP is good for my patient? And is really my patient progressing? And if we have to start a treatment regime for our patient, what would be the best option for the patient? So to address all these questions, there are several studies in the field of primary open angle glaucoma which address the questions and solve the queries to a larger extent. So start with the first ocular hypertension treatment study, which was aimed at two questions. First is that whether the topical medications delays or prevent the glaucoma in ocular hypertension, and second was to identify the risk factors. So with that, the outcome which was monitored after 5 years of follow-up was that 9.5% cases in the observation group and 4.4% cases in the treatment group, they did progress to glaucoma. Now again, there were certain unanswered questions for which OHTS phase 2 had to come up. The unanswered questions were as to if we have to start the treatment, then when should we start the treatment, and if all the OHT cases should receive the early treatment. And to answer all that, the risk factors were outlined, which were the low pachymetry findings, pressures more than 26 millimeters, cup disc ratio more than 0.5, and also the baseline higher pattern standard deviation value. These were supposedly known as the high risk factors. So what do we study from this lesson? What do we infer from this study? That the risk factors should always be considered before starting therapy. There are two things. If there are no risk factors, you can observe the case. If the patient is having any of the risk factors, whether it's a thin cornea, pressures are high, age is little higher side, or the higher PSD, we need to treat the case. Now, again with this study, the role of diurnal variation, the large diurnal variation was emphasized, the study done by Thomas et al. And they said that when we start the patient on OHT, we need to go for a diurnal variation test, and if there is a larger fluctuation, even without the risk factors, we can just give a trial of treatment. So the pearls for the clinician would be that the ocular hypertensive patients at high risk may benefit from close follow-up and early treatment, and the low-risk patients can be monitored with less frequent follow-up and may not need an early treatment. Now coming to the other study, that's early manifest glaucoma trial, which aimed at two things. That for the newly diagnosed POAG cases, whether to start the immediate treatment or can we wait for a while or no treatment. So for this, the exclusion criteria was more important. That was, they did not include the cases who had MD more than 16 decibel, pressures more than 35, and visual acuity less than 20/40. And the endpoint here was to have a progression of field or disc. Now, to summarize, after 6 years of follow-up, they came with the inference that 62% patients in the no treatment group, it progressed. That means a larger amount progressed without the treatment, and the treatment group only 45% progressed. Again, they outlined the baseline risk factors, in which besides the OHTS risk factors, pseudo exfoliation was added, and here they had added that mean deviation should be 4 decibel or worse. So for follow-up visits, they made a guideline that every millimeter reduction of pressure from the baseline reduces the risk of progression by 10%, and disc hemorrhages should be kept in mind when we are monitoring the patient's disease progression. So what do we learn from the EMGT? Treatment is really important when it comes to the purely diagnosed cases. Every millimeter reduction counts, and target IOP needs to be titrated as and when required. It cannot be a single fixed number all the time. Aggressive treatment is definitely required for the patients with high risk factors. And here, again, one more additional pearls for the clinician, that exfoliation syndrome can be considered as an important pressure independent risk factor for the progression. Now, exfoliation, if it is there, we need to monitor the patient closely and start the treatment again. Now, coming to the third study, that's collaborative initial glaucoma treatment study, where the aim was to compare the effect of medical treatment, that's in the form of topical drugs, or the trabeculectomy on early diagnosed open angle glaucoma cases, and also the impact of this treatment on the quality of life of the patient. So it was summarized, and it was inferred that in the surgical group, there was increased risk of visual loss initially due to cataracts, if not performed correctly. And by the end of 4 years, both the groups, whether it was a medical group or the surgical group, the quality of life, they showed similar results. Now, even the subgroup analysis showed that that is always a proven fact, that initial surgery has always been a better options for the patients who are having advanced vision loss, because it reduces the IOP fluctuation to a larger extent. These were the factors which affects the outcome, and the lessons learned from this would be that treatment option should always be discussed with your patients, and surgery can be considered as the first option for the advanced diseases. Now, filtering surgeries, they do give better results, we all know that, and minimum fluctuation should be considered. Now coming to the other study, that's collaborative normal tension glaucoma study. This was really important as the nature of the normal tension glaucoma is unpredictable. Sometimes it goes very slow, otherwise it can rapid progression. So the aim here was that there is any role of IOP when it comes to the etiopathogenesis of NTG, and to learn about the untreated natural history of the NTGs. The exclusion criteria was really important because this is one of the DDs which we make in our clinic when we diagnose a case of NTG, as we say that NTG is a diagnosis of exclusion. So a burnt out glaucoma and a hemodynamic crisis which could affect the optic nerve perfusion was definitely excluded. And the randomization criteria was documented disease progression and a visual field which was threatening the fixation. To summarize, this study stated that lowering the IOP in normal tension glaucoma definitely slowed down the progression, and factors associated with progression, as my previous speakers have been very correctly pointing out, that disc hemorrhage needs to be carefully monitored for migraine and female character. Now talking about the clinical pearls, which this CNGTS we would like to share with the audience here would be that we have to distinguish between a progressive and a non-progressive disease. And progression, as I said, that is highly variable in cases of NTG. More than half are slow progresses, but yes, we need to monitor them. But the most important takeaway would be that surgeries may not be necessarily initiated in the early stages. Now, the last would be that the advanced glaucoma intervention study, where the aim was to see the outcome of laser and surgical interventions in the eyes that have failed on medical treatment and the association between control of IOP after surgical intervention. So to summarize, I can say that in this particular study, the patients were divided into two groups. First, that was subjected to TRAP, then later on to ALT and then TRAP. That was a TAT group. And the other one was the ATT group, where the patients were subjected first to the ALT treatment. And the results was that in blacks, the vision was better with the ALT first, and in whites, the vision was better with the ALT in the initial 4 years, and better in the surgery group later on. The lessons learned would be that TRAP controls the IOP fluctuation better. The risk was definitely a bit higher. Race should always be considered when we are choosing our therapy, and IOP more than 18 and wide IOP fluctuation means your patient definitely needs treatment. Just a second, I'm just finishing it. So take home with the conclusion would be from different studies. EMGT, we can say that lowering of IOP by every millimeter helps in prevention of progression. AG says that if IOP is maintained in the lower teens, most glaucoma will not progress if other factors are not there. CNGTS says that many cases of NTG, they do not progress. But if they do, the only proven method of treatment is IOP lowering. And last but not the least would be the OHTS, which says that all ocular hypertensives, they do not need treatment. If the clinical decision should be taken for the treatment, the risk factors should always be kept in mind. Thank you very much for your patient hearing.
That was a very good overall overview of all the randomized clinical trials, and very well brought out how those clinical trials can be actually transferred into your real-time practice.
Thank you, ma'am.
And very, very specific points that you really need to take from each of these studies and apply them to your day-to-day practice. So you are actually able to practice as a much better glaucoma consultant. You do a lot of justice to your patients. And you have not actually, participated in those trials, but you got so much to pick up from those trials.
Thank you.
Wonderful presentation. Thank you very much. So
With that, with that, we conclude this session of Glaucoma 360 with a varied topics ranging from diagnosis to management. So with that, we conclude the session. We'd request all the speakers to assemble here for a quick photograph before we hand over the session to the others. Next.